So another very important general examination that we do, and we find such a hairy patch or some changes in the skin, some hyperpigmentation or hypopigmentation. All these things are very important in the case of orthopedics as well. So this particular image shows a tuft of hair that is found in the midline of a patient with some deformity around the spine as well. So neurocutaneous markers has an important role in the field of orthopedics as well. So, some light about this
Fine.
particular.
If you see the back of this patient, the patient has a kyphoscoliosis. Scoliosis to the right side. Some degree of kyphosis is visible clinically, and in the lower part of the dorsal spine or dorsal lumbar junction, one can see a patch of hair. Most of these cases with kyphoscoliotic deformity and the patch of hair would be associated with what we call osteopathic scoliosis, which means there would be an irregular segmentation of the vertebral column. Sometimes they are associated with tethered cord syndrome, that the cord is tethered to the vertebral bodies in the lumbar spine. And these congenital defects of the vertebral column may be associated with spina bifida occulta, irregular segmentation of the vertebral column. They may be associated with a tuft of hair or a discolored patch or a collection of fibrofatty mass in or near the site of deformity. If you take an X-ray of this patient, there are very good chances that you will be able to see osteopathic changes responsible for kyphoscoliotic deformity.
So these were some of the pigmented lesions that can also be present, and what exactly should we keep in mind?
Well, in orthopedics, the moment you see a patient with multiple cafe au lait spots, coffee-colored spots, coffee-colored patches, they are associated with neurofibromatosis, may be associated with polyostotic fibrous dysplasia. I think some other, one more. Neurofibromatosis, polyostotic fibrous dysplasia, there's one more. I don't know. What is the significance, they say? If you have a single patch of more than 5 centimeter diameter, it is significant. But a single small patch is of no significance. However, small patches of the size of 1 centimeter or more, 5 in number, are significant. So, a single patch more than 5 centimeter, multiple patches, of course, and even if there are small patches but 5 in number, they are of significance. Broadly speaking, this is the thought today. The thoughts may change by observing more patients, especially with now more sophisticated investigations available to the clinician today.
So that is neurofibromatosis type 1. So there are various criteria in which you consider, like sir has already said, what is the size and what is the number associated with any list nodules. All these things should be kept in mind. Even a genetic tendency is also seen in such conditions, so that also should be asked in your history. Another condition which I think sir was trying to say was pseudoarthrosis of the tibia, the anterolateral type. which is commonly associated with such neurocutaneous markers. So again, commonly asked question is what all orthopedic manifestations can happen in a neurofibromatosis of type 1. So these are the various conditions which you can see: vertebral scalloping, rib penciling, transverse process spindling, vertebral wedging, paravertebral soft tissue mass, a short curve in the apical rotation of the spine, and intervertebral foraminal enlargement, widened interpedicular distances, and dysplastic pedicles. So these are all the spine deformities that you can see in a case of neurofibromatosis type 1.
Neurofibromatosis is generally considered a autosomal dominant defect. In general, they consider, but there are many varieties known. And extremely rarely, neurofibromatosis may be responsible for a neurofibroma situated within the vertebral canal causing neural signs. Extremely rare, though.
Neurofibromatosis lesion in the spine.
Within the
spinal cord.
Vertebral canal. Within the vertebral canal. Rare, but seen, described.
So in today's presentation, sir was mentioning about tethered cord syndrome multiple times, and one major thing which you have to examine is the foot in such spine involvements. So here we have a Cavovarus foot, which is shown over here, and sir, your inputs regarding this particular condition.
Do we have the front view?
So this is the only view.
Oh. Well, we are looking at the foot from behind. One can see that we will look at each item separately. One can see the tendo Achilles standing out. It is tendo calcaneus standing out, looks prominent, which means probably it is tight. Look at the heel. The heel also shows a varus defect. Is heel size more than the forefoot? That is what it gives the impression, which means the patient is predominantly putting a lot of pressure on the heel. When we stand, generally the heel goes into about 5 degrees of valgus normally. Here the heel is about 5 degrees of varus. When we walk, the heel goes into 5 degrees of valgus. Look at the patient. Try to look at these patients when they walk. Have a look on them. We will all understand that the heel, when the heel strikes the ground, there's 5 degrees of valgus on the heel. But here the heel is in varus. If you look at the foot, there is a cavus deformity. One can see the cavus deformity. Normally, the normal foot, when touches the ground, the heel touches the ground, the lateral border of the foot touches the ground, the bases of all the toes, they touch the ground. If a patient is touching the ground without these things touching, then it's called a club foot. So here is a patient probably who has a Cavovarus deformity. The arch is too high. It's a very high arch. So it's called Cavovarus deformity. If the arch is flattened, we call it pes planus. Sometimes the arch becomes convex toward the plantar side or toward the sole side. Then it's called a convex foot, or which is generally caused by congenital vertical talus. So these are 3 different varieties of curvatures of the sole of the foot. Here it seems that there is a significant cavus deformity associated with varus deformity. Probably the cause is either polio or maybe some neuropathic cause in the vertebral column. And that can be judged only by examining the patient neurologically. Is the plantar extensor here? The great toe is in fact showing an upward movement here, which is making you suspect that are we dealing the case of cerebral palsy? I'm not very sure.
Sir, what if in this particular case there is some sensory loss in the foot? Then what should we be thinking about?
No, then it means that either it is a case of spina bifida occulta or spina bifida with tethered cord syndrome, or there is some defect in the neural elements there. Generally, the spinal cord or cauda equina syndromes would give you bilateral features. Here it seems that the right foot appears to be normal, though we are not able to see it fully. But here it looks like a unilateral deformity, but neurogenic condition in the vertebral column can also stay predominantly unilateral. Now one will have to think of a treatment. If it is a sensate foot, it is worth saving it.
So one particular case scenario which I would like to ask you, sir, if there is a unilateral similar deformity with absent reflexes on that particular side, with some loss of sensation on the particular foot, so what should be the first thing that comes to our mind?
You see, in polio, the sensations are not lost. So if the sensation is lost, then polio is excluded. Cerebral palsy is excluded, so which only goes through that there is a damage to the either peripheral nerves or in the cauda equina region.
So a lower motor neuron type
Lower
of a
motor
lesion.
type, yeah.
So in tethered cord syndrome, is it
Also
possible?
it is possible.
It is possible. So a unilateral pathology can happen in case of.
In a tethered cord syndrome, also you can have unilateral symptoms.
So if this is a bilateral deformity, the affected side, I ask him to dorsiflex at the ankle. ऊपर कर लीजिए थोड़ा सा. So that is the maximum. He is able to dorsiflex on the affected side. I try to do it passively. So that is the maximum I can get. I am suspecting some bony block or some TA tightness. I just do the silver scale test to see if that dorsiflexion is coming after flexing the knee, after relaxing the gastrocnemius muscle. So that also is not happening. So that means there is some tightness and restricted ankle dorsiflexion at the affected side. So now this is the inspection from the posterior side. So this is the normal left side. You can see that the heel is in neutral position. You can't see any excessive toes on either side. That means the heel is in neutral. If you see on the medial side, the arch is not so much. It is okay. When you come to the affected side, you can see that the heel is going into varus. So this is the calcaneum. You can see that it is going towards the midline. And when you see from dead posterior, you can see more number of toes on this sign. So that is a peekaboo sign indicating there is a varus in the posterior aspect. So you can see the increased medial arch over here. You can see the heel varus over here. So this would have been a compensatory mechanism to bring these 3 points onto the ground. But as it is a progressive deformity here, there is fixed varus over here, and this particular portion is not even resting on the ground. So this can be one reason for that increased callosity on the lateral side, as I have shown before. Now, to realize whether it is a fixed deformity or not, what we do is a Coleman's test. So for the Coleman block test, I have used a block which is around 2.5 centimeter in height. I have asked the patient to keep his lateral border on the block. What I wanted was the first metatarsal should fall down so that this particular varus gets corrected. So in this case, you can see that the varus is not getting corrected. That means that there is a fixed deformity of the heel. The varus is fixed. So in this particular case, just releasing the peroneus longus might not be sufficient for this case. You might have to do some bony procedures to correct the deformity. So that is the importance of the Coleman block test. Again, you compare the varus on the affected side with the valgus on the neutral side, and if it is not getting corrected, that means a single soft tissue procedure might not be enough. You might have to do more releases on the posterior side as well as maybe a bony procedure to correct the deformity.